Hello, my name is Jose Santiago Esquivel, BSNRN, presenting an admission case regarding a 74-year-old Caucasian female brought to the emergency department after complaining of chest pain. The patient refers to the chest pain as pressure-like and compares it to a stack of books on top of her chest. Pain was radiating to both upper extremities as well as her back. Symptoms onset was while she was lying in bed at home and lasted approximately 10 minutes. She was also experiencing cold sweats as well as associated shortness of breath. EMS was notified and patient was found to be in VTAC and developed VFib. Patient was shocked with 50 joules and was started on aspirin prior to arrival to the emergency room. Review of systems reveal constitutionally, patient was alert, denies any pain, lightheadedness, syncope, seizures, nor fever. Head, she denies any headaches or blurred vision. She denies any hearing loss, nor recent ear infections. She reports good sense of smell, denies any nasal drainage, nor sinus infections. Patient denies any tooth problems. Last dental exam was approximately 10 months ago. Denies any recent sore throat problems. She reports normal breathing, denies orthopnea or any dyspnea while awake. Cardiovascular-wise, positive, of course, for chest pain, localized pressure, intermittent pain radiating to both of her extremities. Patient denies any nausea nor vomiting, denies constipation or diarrhea, no peripheral edema noted nor modeling to any of the extremities. Musculoskeletal wise, patient reports occasional walking, no swimming, denies any gait changes, denies any imbalance nor falls. Endocrine wise, she reports average glucose control. Her most recent hemoglobin A1C was at 7% in the last 6 months. Denies any heat nor cold intolerances, nor excessive thirst nor tremors. Integument-wise, denies any new lesions nor growths and reports some chronic dry skin. Her past medical history includes anxiety, obstructive sleep apnea, hypothyroidism, hypertension, and some insulin resistance. Past surgical history includes 3 prior hip surgeries, turbinate surgery, hemorrhoid surgery, as well as a complete hysterectomy. Significant family history: father died from pancreatic cancer, mother died from coronary artery disease, and she has siblings still living with coronary artery disease. She has no known drug allergies. Social history: she occasionally drinks 1 to 2 glasses of wine a week. Denies any illegal drug use nor smoking. Medications: patient is on metformin, 500 milligrams PO BID. She is on a beta blocker, Nebivolol, 5 milligrams PO daily. Also on NP thyroid, 60 milligrams PO daily. And also taking estradiol valerate at 40 milligrams per ml. And she takes 0.25 mLs IM. Also on hydrochlorothiazide and triamterene, 50 milligrams to 75 milligrams PO BID. Immunization: patient reports to have all of her vaccinations, including the COVID and influenza, for this new season. Physical exam performed reveals general wise, patient was currently in bed with no acute signs of any distress. Head is normal cephalic and atraumatic. Pupils are equal, reactive to light. Oral mucosa was moist, no pharyngeal erythema or oral lesions noted. Her neck was supple, no thyromegaly, no lymphadenopathy, nor JVD noted. Her heart, of course, was regular rate and rhythm. S1, S2 were present, no murmurs on auscultations, no clicks or no rubs. Her lung sounds were clear bilaterally, no crackles nor wheezing noted. Her abdomen was soft, non-tender to palpation. There's no organomegaly noted. Bowel sounds are present to all four quadrants, and they are normal active. Extremities, no peripheral edema noted. Pedal pulses were present. No cyanosis or clubbing noted. And neurologically, patient was awake, alert, and oriented times 4. No focal deficits present. Diagnostics performed. Patient did have a CBC, which revealed red blood cells to be at 3.67, a hematocrit of 35.8, an MCV of 97.5, and an MCH of 33.2. Cardiac enzymes did reveal a very high level of troponin of 3,496. Comprehensive metabolic panel revealed an anion gap of 9.6 with a calcium level of 8.3. Coagulation studies did reveal a PTT of 49 seconds. EKG reveals normal sinus rhythm, no evidence of ST elevation. Cardiology was consulted, and the patient was rushed for cardiac catheterization with findings of 95% mid left anterior descending artery with significant calcification to the proximal and midpoint of the vessel. So the assessment that was obtained, the differential diagnosis includes unstable angina, as well as acute coronary syndrome and non-STEMI. The plan of care to be continued will be patient to be admitted onto telemetry for continuous cardiac monitoring and management. Clinical impression of the patient is, of course, unstable angina secondary to coronary artery disease with a 95% obstruction of the mid-LAD. Patient will be undergoing a repeat cardiac catheterization with atherectomy with cardiovascular backup. Plan for procedure will be within the next 48 hours, so the patient will remain in a cardiac and diabetic diet until then. Patient will be continued a heparin drip, as well as aspirin, statin, and the beta blocker regimen. TSH will be ordered, as well as hemoglobin A1C. Patient will be placed on NPO at midnight prior to the day of the procedure, and follow-up and consultation for cardiology to see what they recommend.